Greetings of the day, folks. Today we are going to discuss about congenital adrenal hyperplasia, or known as adrenal insufficiency from the birth. Okay, so congenital adrenal hyperplasia results from an autosomal deficiency in one of the five enzymes involved in the production of cortisol. Okay, so this is adrenal gland produces cortisol, androgens, and also mineralocorticoids like um aldosterone, then cortisone, than the sex hormones androgens. So absence of these enzymes leads to decreased conversion of 17 hydroxyprogesterone to 11 desoxycortisol with resultant cortisol deficiency. So most of these enzymes also impair conversion to progesterone and 11 desoxycorticosterone in the mineralocorticoid pathway, which leads to decreased aldosterone production too. Okay, so deficiency of the 21 hydroxylase comes for most cases. 75% of the affected newborns manifest with classic salt losing virilizing variant in which urinary salt wasting with hyperkalemia and hyponatremia dominates the clinical picture. 25% of cases are in the non-salt losing simple virilizing type. Infants with salt losing forms of congenital adrenal hyperplasia typically present during second to fifth weeks of life in crisis, sometimes before the results of newborn screening tests are available. Okay, so coming to the pathophysiology. So congenital adrenal hyperplasia is a group of disorders of adrenal steroid biosynthesis that results from a defect in one of the five enzymes. Let's look into the enzymes, the various enzymes. Okay, so the this is the flow diagram of the adrenal steroids synthesis and also the various. You can see here this is adrenal cortex. Okay, adrenal cortex has got the zona glomerulosa, fasciculata, and reticularis. So in the glomerulosa, there will be a synthesis of mineralocorticoids. In the fasciculata area, there will be glucocorticoids, that is cortisol, and in reticularis there will be androgens or sex hormones. So there is a mnemonic for this. Uh, when we go from outside to inwards, the sweetness increases. That is salt, sugar, and sex. Okay, that's an easy way to remember the synthesis of various hormones by the adrenal gland. Okay, so the predominant raw item, the main component that gets converted into all these is the cholesterol. The cholesterol, under the influence of the cholesterol desmolase enzyme with the positive feedback from the ACTH, gets converted to pregnenolone. Pregnenolone, which gets either directly converted to progesterone, then 11-deoxycorticosterone, then corticosterone, then aldosterone. Okay, we will discuss the various enzymes later. So then the pregnenolone can also be converted on the influence of 11 alpha hydroxylase to 11 hydroxypregnenolone, then which can be gets converted to 11 hydroxyprogesterone and 11 deoxycorticosterone and cortisol. Then the 11 hydroxypregnenolone can also be converted to dehydroepiandrosterone, okay, DHEA, which gets converted to androstenedione, and under the influence of aromatase in the peripheral tissue, that is in the then the ovaries, can convert to estrone or estradiol. Okay, so it gets converted to testosterone also. Androstenedione can be converted to testosterone under the influence of okay, so testosterone and also alpha under the influence of 5 alpha reductase, it gets converted to dihydrotestosterone. Okay, so here you can look here the main enzymes that will be responsible for which we see most commonly are the 21 hydroxylase enzymes, which converts progesterone or 11 hydroxyprogesterone to 11 deoxy corticosterone and 11-deoxycortisol in respective zonal glomerulus and fasciculata. And 11-beta hydroxylase converts the 11-deoxy corticosterone to corticosterone and 11-deoxycortisol to cortisol. So when there is a deficiency or when there is deficiency in these enzymes, then it may lead to adrenal insufficiency. Now let's go back to our discussion. So, depending on the specific enzymes, cortisol deficiency may be accompanied by mineralocorticoid deficiency, leading to hypoaldosteronism with resultant salt wasting. So, because hypothalamic pituitary axis is suppressed by cortisol, the deficiency results in increased secretion of ACTH without feedback suppression. So this uninhibited excess ACTH stimulates adrenal gland, which leads to hypertrophy. This causes adrenal hyperplasia or hypertrophy. So elevated ACTH can also cause hyperpigmentation of the skin, which is best observed on the labial or scrotal folds and the nipples. Steroid hormone precursor upstream of enzyme defect buildup are shunted to alternate pathways. So when there is deficiency in 21 hydroxylase, it leads to accumulation of precursors that are metabolized to androgens. Okay. So when there is deficiency in 21 hydroxylase, it leads to accumulation of precursors that are metabolized to androgens. So this in turn causes virilization of the affected females, which manifests as clitoromegaly. Affected males, if the patient is male, then it may go undetected at birth and because the genital appear normal. So coming to the clinical features, the most of the patient will be having salt wasting variants. Okay, so most of them will have an acute crisis in their second week of life, and symptoms include like lethargy, irritability, poor feeding, and vomiting, and poor weight gain. Okay, because there is salt wasting. And depending on the duration and severity of the symptoms, infants may present with significant dehydration or even shock. So we have to obtain complete history of the presenting symptoms because differential diagnosis of salt wasting crisis includes sepsis, congenital heart disease, and other inborn errors of metabolism. So we have to review the gestational age and birth weight also, and also the maternal history regarding complications of pregnancy, prior pregnancies, miscarriages, spontaneous abortions, so and previous infant deaths. So we have to obtain results of newborn screening. So after that, it's a physical examination. Now coming to the physical examination, it will be some. So after history, we'll record vital signs and weight and assess hydration and mental status. So complete head-to-toe examination should be done, and we should carefully examine the genitalia, mainly in the females, because there will be a clitoromegaly. So males will have a normal genitalia or a small phallus or a hypospadiasis. Note any We have to note any hyperpigmentation. Okay, so coming to the diagnosis, the most important laboratory studies are bedside glucose level and serum electrolyte levels. So although hypoglycemia is rare, poor feeding and vomiting may cause secondary hypoglycemia, which requires urgent treatment. The classic electrolyte abnormalities in salt wasting, congenital adrenal hyperplasia, or hyponatremia and hyperkalemia. So serum potassium level may be elevated to between 6 and 12. Although changes in cardiac function and ECG are unusual, metabolic acidosis typically accompanies classic electrolyte abnormalities as a result of aldosterone deficiency and dehydration. Okay, so which will classically metabolic acidosis will be seen, and so serum potassium level will be elevated and there will be hyponatremia. And definitive diagnosis mainly by analysis, analyzing the blood hormone levels, and also we have to obtain a steroid profile prior to treatment. Okay, so if the patient is critical, we should not wait for the investigations. Okay, so we have to directly, if we suspect adrenal salt wasting crisis, then we must supplement the steroids. Okay, so although infants generally tolerate hypokalemia well, often it will lead ECG because hypokalemia changes may alter emergent treatment and disposition. So treatment, no imaging and are not routinely indicated or helpful for the individuals. So treatment because there is circulatory collapse due to adrenal crisis. We must so initially we will administer fluids, that is 10 to 20 milliliters per kg um, of normal saline. Bolus will be given. Then fluid loss in is isotonic, right? So fluid replacement should be with normal saline. And for hypoglycemia, because if the cortisol is involved, then 5 ml per kg of 10% dextrose should be administered. So if the patient is neonate, then we must administer 25 milligrams of hydrocortisone, or if the patient is a toddler, then we must administer 50 milligrams of hydrocortisone. Then if the patient is adolescent, then 100 milligrams of hydrocortisone should be administered. Okay, so there was some mineralocorticoid effect on a higher dose of hydrocortisone that we must remember. If hypocalcemia results in ECG changes, it is better to first we have to give calcium gluconate to stabilize the membrane, that is 100 milligrams per kg or 1 ml per kg, and sodium bicarb 1 milli equivalents per kg. So we normally in adults will give insulin and glucose for hyperkalemia, but in infants we must be careful that it may result in profound hypoglycemia. So we should not give insulin and glucose for hyperkalemia. Okay. So the administration of normal saline and hydrocortisone is usually sufficient to lower the serum potassium levels in the absence of cardiac manifestations. So for the disposition, all infants with salt wasting require admission to hospital, and infants with signs of shock or severe hyperkalemia with ECG changes should be admitted to intensive care unit with endocrinology consultation. This completes this video. Thank you very much.